Hi, my name is Shanna Miranti. I'm a dermatology PA from Naples, Florida. Welcome to Grand Rounds in Atopic Dermatitis. I am joined by my colleague, Dr. Shahriari, who is a fabulous dermatologist from Connecticut, who will be joining me today. We'll be discussing some cases in our atopic dermatitis patients. Welcome.
Thank you so much for having me.
Absolutely. So let's dive into our first case. Please meet 22-year-old Layla. Layla is a beautiful female who has a long history of atopic dermatitis and allergies from when she was much younger. But now the AD has seemed to rear its ugly head and is most pronounced on her face and neck in very visible areas. She gets extremely itchy, and it tends to be very exacerbated by the cover up, the makeup, and the skincare that she often goes to try to camouflage her AD. She's very bothered by the dyspigmentation. It can go hypopigmentation or hyperpigmentation, depending upon the UV index in Florida. I feel like it does change quite a bit. So she's tried and failed a lot of different things. She's tried topical steroids, and she says she does not like them because it makes her skin look whiter. She feels like steroids actually change the color of her skin tone. She does not like TCIs because she says they just didn't work for her in the past. And crisaborole has burnt her to a crisp, unfortunately. So her PMH is, again, she has that history of atopy, allergies, and AD. I'm also concerned she may have a little contact dermatitis going on from some of the skincare she's been using, or maybe some of the preservatives in the skincare that she's been using. She has a very small BSA, but it's in a very sensitive skin area on her eyelids, on her face, on the anterior portion of her neck. It's an IgA of mild, I would say, typically most days, but it's still extremely bothersome to her and very, very itchy.
So Shanna, I think this is a fantastic case to really show us patients who have melanin-rich skin, their experience with their AD can be a little different. I
Yeah.
love how a lot of the symptoms she's having are actually not specifically related to the AD, but related to the dyspigmentation. And as you just mentioned, the pigmentary changes aren't really used in any of our assessments of disease severity. So we don't really count them as a point to understand the severity of disease and determine if we need to go to fancier medications. The other thing is what I find in our skin of color patients is oftentimes the itch is out of proportion to what we're seeing from a BSA and IgA standpoint. So she really represents the bread and butter patient that we see who has melanin-rich skin in our clinics.
For sure. And you nailed it. I mean, she's so bothered by that itch. And when you look at it, you can feel a little textural change, but truly it's hard to assess inflammation in some of our skin of color patients. So I did start her on ruxolitinib cream, and she got such a fantastic improvement in itch very quickly. So I think the impetus was certainly to get that itch better so that she stopped scratching, so that there was not as much lichenification. And so she didn't really feel the need to camouflage and cover it up, which was probably making everything worse. She started ruxolitinib cream BID to all affected areas on her eyelids, on her face, on her jawline, on her neck. We reviewed her skincare, which was critical because I think she was using a lot of potentially over-the-counter, Sephora options, I like to call them, recommended by the lovely makeup artists at Sephora.
They keep us in business.
They do. They really do. But, she truly was able to peel a lot of that back. We got her on very clean skincare without parabens, without preservatives, without fragrance or formaldehydes, and a lot of those ingredients that are so bothersome to our AD patients. She now started wearing a tinted sunblock, and we had a great conversation about that all skin tones, not just fair Irish skin, need that sun protection, especially in Southwest Florida, where we get so much sun exposure and where that could be contributing to a lot of her dyspigmentation. So she's much, much less bothered by the hypopigmentation at this point. It's only 1 month later, and she's looking so much better.
I think that 1 month photo really speaks volumes as to how well this ruxolitinib is working for her. Because I know my patients with skin of color, they're sometimes bothered more by the pigmentary change than the AD itself. And with
Oh,
every
absolutely.
Yeah, and with every scratch, there's that potential for more pigmentary change. So I think the ability of topical ruxolitinib to cool down that itch so quickly is evident here because now you can see the skin finally having a chance to heal.
Yeah, fantastic.
Now, I'll share a case of mine. This is 58-year-old Nathan, and he's had atopic dermatitis since childhood. He's tried and failed topical steroids, calcineurin inhibitors, even oral prednisone. And his past medical history is positive for hypertension. He is a smoker, diabetes, asthma. But when you look at his exam, he's pretty severe. We're talking a BSA of 65%. The IGA is a 4 or severe, and that itch score is a whopping 7. So when Nathan came to see me, we were discussing what is the next step for him. And when you have so much BSA, topicals are sometimes just not feasible. And oftentimes the burden of treatment is going to be just as important as the burden of disease. So I discussed orals versus injectables with him. And due to his history of asthma and some of his other comorbidities, we decided to start on dupilumab. Would you have any other points to point out with him?
That's a great point. So the fact that, we do have to sometimes make those clinical decisions. Of course, patients don't always want to jump right to a systemic. Sometimes they feel like, no, I can control this. I can take care of this. And sometimes we have to remind them, this is just a little bit beyond what you can control. And that's okay. It's not your fault. Your AD is a bit out of control at the moment. And so we need to have that conversation about when to move on to systemic therapy. And sometimes that does come with some more discussion or deeper discussion into potential adverse events. I would absolutely agree with you, given the fact that he's over 50 and a smoker and has a pretty significant cardiovascular history. I don't know that I would be quick to want to start him on an oral JAK inhibitor, systemic JAK. I think absolutely going to the therapeutic biologics was the right thing to do.
So let's see what happens. He was on dupilumab for 6 months and he came back to see me. And as you can see, he's better, but he's certainly not adequately controlled. And when you look at his objective assessment, his BSA is still 10%, which from a 65% is pretty darn good, but not perfect. IGA is 3 and his itch score is still a 4. And so really, when I see patients like this, we need to challenge ourselves to ask the questions about adequate control and make sure the patient is where they want to be, because being kind of sort of better just in the year 2025 is not good enough. And I love to use the ahead recommendations when I'm making decisions, which is aiming high in eczema and atopic dermatitis. And that really tells us that if we start a patient on a new systemic agent, in a matter of 3 to 6 months, our goal should be to get them to an itch-free state or an itch score of 0 or 1. From a skin clearance standpoint, we want them to get to about an easy 90 or clear, almost clear skin. Or if you're someone who likes to use IGA criteria, is 0 or 1. And then if we're not there, that's when I start to think about maybe it's time to switch to a different therapy. Is that how you approach these cases, Shanna?
Absolutely. Patients want to be better yesterday. And of course, they want 100% improvement, but they want that 100% improvement with the least amount of work possible. And that's not always possible. So I think what's beautiful about this case too is even though it is from a 65% BSA down to a 10% BSA, that's a difficult 10% to reach, if it's on his back. And is he going to be able to take care of that with concomitant topical therapy? Probably not. So given the fact that he's not adequately controlled, what was your next step? What did you do next?
Well, the first thing I need to decide is he a primary failure or is he a secondary failure? And primary failures are usually patients who you start them on an agent and you really don't see much of a response. Secondary failures are patients who you see a response, but maybe it isn't good enough or they do well for a while and then they stop responding. So he fell into that category. So I was like, you know what? The biologic mechanism seems like it may work for him and it is a safe option. However, maybe Dupy is not the perfect option for him. So I actually switched him over to lebrikizumab. And after 4 months, he was actually 100% clear. And his BSA was down to 0%, IGA 0, itch score of 0. And sometimes I have people ask me, well, if they fail one biologic, aren't they going to fail the rest? And this is a perfect example of the highly heterogeneous nature of AD. And our patients have so many different endotypes, and you don't know which cytokine is the key player for a lot of these patients. So I've seen cases like this where when one agent maybe doesn't do as well as we'd like, another agent could be a blockbuster. And one of the reasons I think Lebri shined for me is they have data that shows in DUPI inadequate responders, it can actually be just as effective as patients who are bio naive. What are your thoughts?
Absolutely. Absolutely. And, you are so, it's so true. We do not have a cytokine crystal ball. We don't know exactly which cytokines are their cytokines that are actively at play here. And since there is that great binding affinity for the IL-13s, I think that this was a really, really smart choice to go to another biologic. Again, given his comorbidities, we want to stick with therapies that are going to give their patients both the efficacy and also keep them very safe and free of some of those potential pesky side effects. So this was a really nice outcome for this patient. I'm sure he was very, very happy.
Oh, he was. And one of the reasons actually I picked lebrikizumab over tralokinumab, for example, which is another IL-13, was he has a history of asthma. And obviously, dupilumab has incredible data in asthma. Lebrikizumab does show efficacy in a certain subgroup of asthma patients. So I thought, you know what, this might work for him. And it actually did. Tralokinumab, unfortunately, doesn't have that kind of data. So that's why I shied away from it. But if it wasn't for the asthma, I think Tralo would have been just as good of an option to try.
Absolutely. It's just so great that we have options, and it's fantastic to know that we can switch within a class of biologics because of the different cytokines and because we are hitting different targets. We can get an even better response for our patients.
Absolutely.
Thank you so much for reviewing these fantastic cases, and please stay tuned for new episodes of Grand Rounds in Atopic Dermatitis.